Hello everyone, welcome to Mediverse Atlas. In today's video, we are going to talk about brachial plexus. It is an important LAQ, sometimes asked as an SAQ in our theory exams. And don't miss the clinical anatomy of brachial plexus because the question from brachial plexus will be of scenario based. So you need to be very thorough of the clinical anatomy of the brachial plexus. Now, let us start with the definition of brachial plexus. So, brachial plexus is the nerve plexus derived from ventral primary rami of lower four cervical nerves, that is C5 to C8, and the first thoracic spine, that is T1. Now, let us try to understand this definition in detail. I'll just give you a small overview on this ventral primary rami. What does this exact ventral primary rami mean? Think this as a spinal cord. From the spinal cord, we have two roots, the ventral root and the dorsal root. These two roots, they join to form a spinal nerve. Okay, they join to form spinal nerve, and this spinal nerve is again divided into ventral rami and dorsal rami. So this is the ventral rami and this is the dorsal rami. So from this ventral rami, the brachial plexus emerges. Okay, this is the exact meaning of the ventral primary rami. Now, it is written like as the lower four cervical nerves, that is from C5 to C8, and the first thoracic spine, that is T1. So the root values of brachial plexus, like the roots from where brachial plexus emerges, are C5, C6, C7, C8, and T1. Okay, now let us look at the components of brachial plexus. Brachial plexus has roots, trunks, divisions, cords, and branches. Okay, again, this trunks has upper trunk, middle trunk, and the lower trunk. Divisions, they have anterior divisions and posterior divisions. And cords are again three. Those are lateral cord, medial cord, and posterior cord. And branches are from the cords of brachial plexus. Okay, now let us look at this diagram of brachial plexus. I know this diagram is a little bit scary, so if you are okay with it, you can represent like this in exam, or else we'll try to learn the schematic diagram of brachial plexus. See, I have written the roots of brachial plexus here. Okay, so these are the roots of brachial plexus: C5, C6, C7, C8, and T1. And from the roots, we have trunks. Right? How are these trunks formed? C5 and C6 root, they join to form the upper trunk. Okay, C7 continues as the middle trunk, whereas C8 and T1, they are joined to form the lower trunk. And as we have discussed earlier, trunks has divisions. They have two divisions, anterior division and posterior division. Upper trunk has an anterior division, middle trunk has an anterior division, and lower trunk also has an anterior division. Now, in a similar way, all these three has posterior divisions also. Okay, now let us draw the posterior divisions. So these are the posterior divisions of the trunks. Now, these divisions are joined to form the cords. Now, this is the most important part. How can we form cords from these divisions? We'll be looking at it. Now, we'll join the anterior divisions of upper trunk and the middle trunk. This forms the lateral cord. Now, we'll be joining the posterior divisions of all the trunks. This forms the posterior cord. Now, we'll be continue the anterior division of lateral cord, which forms the medial cord. Okay, I hope you got my point. C5 and C6 roots join to form upper trunk. C7 continues as middle trunk, and C8 and T1, they join to form the lower trunk. And upper trunk has anterior posterior divisions. In a similar way, middle and the lateral trunk also has the lower trunk also has the anterior and posterior divisions. Right, now to form cords, first we'll be joining the anterior divisions of upper trunk and the middle trunk, which forms the lateral cord. Now we'll be joining the posterior divisions of all the trunks to form the posterior cord, and we'll be continuing the anterior division of lateral trunk to form the medial cord. So this is the schematic representation of brachial plexus. You can represent like this in the exam for time saving. Okay, so till here these are roots, these are trunks, these are divisions, and these are cords. From cords, branches emerge. Okay, first we'll be discussing each of the every component in detail. First, we'll be talking about roots. In roots, we will be talking about prefixed plexus and postfixed plexus. Normally, brachial plexus is from C5, right? Brachial plexus is called prefixed plexus when the root value of brachial plexus starts from C4. Okay, that is in prefixed plexus, the root value of brachial plexus will be C4 to C8. This is the prefixed plexus, whereas in postfixed plexus, the root value of brachial plexus do not start from C5, it starts from C6. So the root value continues as C6 to T2. This is the postfix plexus. Okay, now trunks, as we have discussed earlier, C5 C6 join to form the upper trunk, C7 continues as the middle trunk, and the C8 T1 continues as the lower trunk. Okay, and to remember, this is a very important MCQ. These trunks are located in neck between scalenus anterior and scalenus medius. Okay, so in the between the scalenus anterior and scalenus medius, trunks of brachial plexus are located. Now, divisions. Each trunk is divided into anterior division and posterior division, that is ventral as well as dorsal division. Next, chords. As discussed earlier, lateral chord is formed by the anterior divisions of C5 and C7. See, this is the lateral chord. From the anterior divisions of C5 and C7, this lateral chord is formed. In a similar way, medial chord is formed by the anterior divisions of C8 and T1. Okay, so medial chord is formed by the anterior divisions of C8 and T1. Anterior division form of medial chord. Next, posterior chord. All posterior divisions. We have seen all the posterior divisions, they join to form the posterior chord. Okay, now we will be talking about the branches of the brachial plexus. So there are branches from roots, branches from trunks, and branches from cords. So there are two branches emerging from the roots. So these are long thoracic nerve and dorsal scapular nerve. Long thoracic nerve is also known as nerve to serratus anterior, and dorsal scapular nerve is also known as nerve to rhomboides. So these are the two branches from the roots. Okay. Next, the branches from trunks. So arise only from the upper trunk. So these are suprascapular nerve and nerve to subclavius. These are the two nerves emerging from the trunk. See, you need to remember these branches, nothing to do with it. Okay, with practice, with revision, you can remember these branches. Okay, so branches from roots are two. Those are long thoracic and dorsal scapula, and from branches from trunks are again two. And the branches from trunk arise only from the upper trunk. Those are suprascapular nerve and nerve to subclavius. Next, branches of the cord. So what are the branches from the lateral cord? So remember the branches of lateral cord as LML, mnemonic. So lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. Okay, next, branches from medial cord. Remember it as M4U, that is 4 M's and U. So what are these 4 M's? Medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, and U is for ulnar nerve. Okay, so medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and medial root of medial nerve, and finally ulnar nerve. So these are the branches from medial cord. Now what are the branches from posterior cord? Remember this mnemonic as lunar, Lunar, lunar. Okay, many will be telling you to remember as ulnar because ulnar is a separate nerve. So in exam we may confuse and include ulnar nerve in the posterior cord branch. So to avoid the mistake, remember it as lunar, Lunar. So what are the abbreviation of this lunar? L is for lower subscapular nerve, U is for upper subscapular nerve, N is for nerve to latissimus dorsi, A axillary nerve, R is the radial nerve. Okay, now we are going to talk about the clinical anatomy of brachial plexus. In clinical anatomy of brachial plexus, we will be studying about two major paralysis, that is Erb'S paralysis and one is Klumpkes paralysis. Okay, these two are the major important clinical anatomy of brachial plexus. We will be studying it in detail. First, Erb'S paralysis. Erb'S paralysis of arm. It is the paralysis of arm. It is caused by injury to upper trunk of brachial plexus. So if there is an injury to the upper trunk, so we can manifest this Erb'S paralysis. Now what is the site of injury? The site of injury is the Erb'S point. Now what is this Erb'S point? It is the region of upper trunk where 6 nerves meet. Okay, see, these are the roots C5 and C6, and these are divisions, anterior and posterior division. This is the upper trunk. So there are 6 nerves meeting at this point. So there are 2 nerves like there, there are two nerves of the division, and there are two nerves here, the suprascapular nerve and now the subclavius. So these are the only two branches emerging from the trunk, right? We have studied. So where the six nerves meet, this point is known as Erb's point in the upper trunk. So if there is an lesion or the injury here, we can manifest Erb's paralysis. Okay, so this point is known as Erb's point. Now, what are the nerve roots involved? Obviously C5 and C6, because it is a lesion of upper trunk, right? Now, what are the muscles paralyzed? So muscles paralyzed are biceps brachii, deltoid, brachialis and brachioradialis. So almost all the anterior compartment of arm, right? Next, partly supraspinatus, infraspinatus and supinator. So in short, the anterior compartment of arm is affected. Okay, so biceps brachii, deltoid, brachialis, brachioradialis, supraspinatus, infraspinatus and supinator. Now, what is the cause of injury? So it is due to the undue or the extreme inseparation or the inappropriate separation of head from arm. It is commonly caused in difficult birth injury and fall on shoulder and during anesthesia. So these are the causes of injury. Now, what is the deformity and position of limb? So what happens to arm? So arm hangs by side, adducted and medially rotated. So it is adducted and is medially rotated. Now what happens to forearm? Forearm is extended and pronated. So this extended and pronated forearm is known as policeman's tip hand, waiter's tip hand or potter's tip hand. See, you can see here. So this is extended and it is pronated, and this type of manifestation, it is known as policeman's tip hand or waiter's tip hand or the potter's tip hand. Okay, this thing. Now look at this picture. We can see the arm is adducted, it is adducted and it is medially rotated. Okay, so this is adducted and medially rotated, and forearm is extended, pronated. You can see this deformity, policeman's tip hand, in this picture. Now what is the disability? So disability will be, we can study the disability under two headings, that is motor loss and the sensory loss, because we are talking about the nerves. These nerves supply motor and the sensory innervation to many muscles. So if there is a disability, the motor and sensory part will be affected. So what is the motor loss? It is the abduction and lateral rotation of arm at shoulder joint. Okay, we cannot perform abduction and lateral rotation, okay, at the shoulder joint. Now flexion and supination of forearm is also lost. Now what is the sensory loss? Sensory loss over the lower area of deltoid. Okay, so this is the deltoid, right? From the lower this area of deltoid, there is sensory loss also. Now motor loss will be abduction is not possible, even lateral rotation is not possible, and flexion and supination is also not possible. Okay, now Klumpkes paralysis. This Klumpkes paralysis is the injury to lower trunk of brachial plexus. Erb's is because of the upper trunk. This Klumpkes is because of the lower trunk. So in this mainly there is paralysis of hand muscles. Now what is the cause of injury? It is due to undue abduction of arm. Okay, it is the inappropriate abduction of arm. Okay, now what are the nerve roots involved? I hope you are clear with the terms abduction, adduction, rotation, medial rotation, lateral rotation. If you are not, please do read general anatomy once again. Okay, so the cause of injury is due to the inappropriate or the extreme or the undue abduction of arm. Nerve roots involved are C8 and T1. Now what are the muscles paralyzed? They are ulnar flexors of wrist and fingers and intrinsic muscles of hand. Okay, so basically flexors of wrist and fingers are affected, mostly the ulnar flexors, that is the muscles supplied by ulnar nerve. So and the intrinsic muscles of hand are also affected. Now what is the deformity in the position of hand? It is the hyperextension at metacarpophalangeal joints and flexion at the interphalangeal joints. So you can see this is basically a claw hand. We'll be calling it as the claw hand. Okay, it is the claw hand. What is it written here? Hyperextension at metacarpophalangeal joints. So there is hyperextension at metacarpophalangeal joints and flexion at the interphalangeal joints. Okay, so this is the hyperextension at metacarpophalangeal joints and there is flexion at interphalangeal joints. I hope you are clear. So this deformity is known as claw hand. Now what is the disability? That is the complete claw hand. And again one more disability is the cutaneous anesthesia. Cutaneous anesthesia means loss of sensation in the cutaneous part of hand. analgesia, that is loss of pain in a narrow zone along the ulnar border of forearm. Now what is this ulnar border? We'll be looking at. See, the side of the thumb, where our thumb is present, that is the lateral side. The side of the little finger is the medial side. This is the lateral side, this is the medial side, and the medial side, it is mostly innervated by ulnar nerve. So this medial part, it is known as the ulnar border. So at this ulnar border, there will be loss of anesthesia, that is sensation, and there will be loss of pain, that is analgesia. Analgesia is loss of pain, anesthesia is loss of sensation. So there will be cutaneous anesthesia and analgesia at the ulnar border, that is at the medial side of the arm and forearm. So this is the disability. Now we must discuss this something about the Horner's syndrome in this the Klumpkes paralysis. So now what is this Horner's syndrome? Horner's syndrome is the loss of sympathetic supply. Now, so in Klumpkes paralysis, there is injury to T1. So now this T1, it carries sympathetic fibers that supply eye and face. So when this T1 gets injured, it produces a classic triad leading to ptosis, meiosis and anhidrosis. Now what is this ptosis? Drooping eyelid. Meiosis is constriction of pupil. Anhidrosis is loss of sweating. Okay, because of the T1 injury to T1, there will be ptosis, meiosis and anhidrosis, which leads to Horner syndrome in the Klumpkes paralysis. And enophthalmos and loss of the ciliospinal reflex is also seen. Okay, enophthalmos is the shrunken eyeball. So enophthalmos and loss of ciliospinal reflex is also seen. Now what are the vasomotor changes? So arteriodilation. Vasomotor means the activity of the blood vessels. Motor means activity, vaso means blood vessels. So the activity of the blood vessels also changes in the Klumpkes paralysis. So what are these changes in activity of blood vessels? So arteriolar dilation, that is vasodilation at the area of its sensory loss. That at the ulnar border there will be arteriolar dilation. Because of the arteriolar dilation, there will be warm sensation also. Okay, now what are the trophic changes? The trophic changes are the long-standing Klumpkes paralysis. If untreated, it leads to cracking nails with atrophy of pulp of fingers. Okay, so this is about the Klumpkes paralysis. Thank you for watching our video, and please do follow us in Instagram and Telegram. Bye.